we hear from many eminent speakers on various neonatal brain and neurodevelopment problems related to that. So today, the topic will be the neonatal pain and brain effects of sedation and analgesia, which is considered as a hot topic, which is discussed at various conferences wherever you attend. You keep hearing about this topic because the things are changing. There are new medications being added to our practice. We have an eminent speaker in this field today. It's a pleasure and honor to introduce to you Dr. Christopher McPherson, who is at Missouri. So Dr. McPherson is currently a clinical pharmacist in the neonatal intensive care unit at the St. Louis Children's Hospital. Dr. McPherson graduated from University of North Carolina School of Pharmacy and later completed fellowship in neonatal pharmacotherapy at the Women's Hospital of Greensboro. And Dr. McPherson worked in areas like pain, neonatal brain.
Bit, but not just to show off.
In addition to caffeine and therapeutic hypothermia, medication use in babies receiving therapeutic hypothermia. So without wasting valuable time, I give it over to Dr. McPherson. And before giving over, just a few housekeeping rules. Please mute your microphones or other devices throughout the presentation. However, you can still type the questions in the chat box on your right side. And either you can do it as we go, or you can also do it at the end of the presentation. Dr. McPherson, thank you and welcome virtually to Cleveland Clinic.
Thanks so much, Dr. Carnati. I'm really disappointed that I can't be actually in Cleveland Clinic, but I really appreciate this opportunity as the next best thing given the current state of the world. So it's really a tremendous honor to speak to this group. And as soon as I get my slides pulled up, I hope you're seeing my screen now.
Yes.
And I'll just really briefly go through this, as Dr. Carnati said, a really hot area in terms of improving the care of our babies, not only the compassionate care, but also care as it pertains to the long-term developmental outcome of these babies. I can't really emphasize how important this aspect of care is. And hopefully that'll be clear from all the material I present today. So in terms of background, I've definitely cut out a lot of material from much longer talks that I give on this topic, but I don't want to underemphasize that material all the same. Analgesia to treat acute pain is clearly beneficial, so I won't go over that relatively old data, but it's really important to understand that in the setting of major acute pain, analgesia dramatically improves both the short-term and the long-term outcomes of babies that are treated with it. So we're definitely far, far away from the era where we can when we can ethically do major surgeries or even moderately painful procedures like endotracheal intubation without the benefits of analgesia and in many cases sedation as well. However, I'll spend the majority of this brief talk on the role of continuous sedation and analgesia to treat chronic agitation and discomfort, because that's much less clear in our practice. It's obvious that during short durations of mechanical ventilation, when your goal is primarily rapid extubation of the baby, that you're not going to be using continuous sedation and analgesia in those circumstances. Alternatively, when physiology clearly requires synchrony, PHN, or air leak syndromes, multimodal continuous sedation and analgesia are of utmost importance in those clinical circumstances. However, I'll focus on two areas, one for the majority of talk, and then at the very end, I'll talk about therapeutic hypothermia. But the bulk of the talk will focus on premature babies undergoing relatively long durations of mechanical ventilation. The AAP and the Canadian Pediatric Society are relatively clear on this. They say avoid routine use. However, a recent statement from the Italian Society of Neonatology suggested an approach foundationed on fentanyl and morphine titrated to scores. These are two very contrasting approaches. So I just want to take the group through the data today to see where we might land in our own practices, knowing that we would love to avoid these pharmacologically active agents in babies that appear comfortable on stable invasive mechanical ventilation. But we've all been in the circumstance in our neonatal unit where the medical team, including the doctors, the nurses, all the bedside caregivers, are perceiving pain and agitation in a baby on stable mechanical ventilation. What's the best approach in that circumstance? How can we safely sedate that baby with both compassionate care considering short-term clinical outcomes, and care considering long-term neurodevelopmental outcomes? So first, I'll talk really briefly about GABA agonists, specifically midazolam. You'll see this slide pop up several times in the presentation. This is my cartoon of a neuron in the brain that helps me understand how these drugs are working and how that might have implications on both short-term and long-term outcome. So we're looking at presynaptic neurons in the brainstem, medial thalamus, cerebral cortex, amygdala, caudate, putamen, diffusely throughout the brain. These neurons are at baseline negative charge, which means they're just not transmitting glutamate across the synaptic cleft. When a painful or agitating stimulus occurs, adenylate cyclase converts ATP to cyclic AMP. Calcium influxes into the neuron, which changes the polarity of that neuron to positive, causing the release of glutamate, which carries that signal from the presynaptic to the postsynaptic neuron. At the same time, potassium effluxes, which repolarizes the neuron and allows for re-stimulation. So you can have repetitive carryover of repetitive release of glutamate from that neuron, carrying forward a painful or an agitating stimulus. Now, focusing on, as I said, GABA agonists, midazolam specifically, these bind to the GABA receptor, which allows the influx of chloride. Now, chloride is a negatively charged ion, so that hyperpolarizes the neuron to a negative resting state. So these are sedatives because they make it harder for that neuron to be activated and to carry that agitating stimulus from presynaptic to postsynaptic. But when you have that agitating stimuli, as emphasized by the white lightning bolt here, you have a much smaller release of glutamate because of the hyperpolarized negative charge of that neuron. Midazolam doesn't have a really profound role in our clinical practice in preterm neonates, and that's primarily on the basis of the no pain trial. You can see the short-term neurologic outcomes that were emphasized in the no pain trial, including severe IVH, PVL, and death. You can see this was a randomized controlled trial that randomized roughly 66 babies to one of 3 interventions: continuous infusion of placebo, midazolam, or morphine for babies undergoing early stable mechanical ventilation. And you can see in this pilot trial, the morphine group did very, very well, had a very low rate of severe IVH, PVL, or death. However, the midazolam group, in contrast, did very poorly. 1 in 3 of the 21 babies randomized in this trial had one of those severe adverse neurologic outcomes. Why is that? It's predominantly related to hypotension. So on the top half of this slide, you can see the impact that a midazolam bolus has on mean arterial pressure in a premature baby. A pretty significant sustained decrease in MAP. But what's even more concerning is on the bottom of the slide when you look at mean cerebral blood flow velocity. You can see a much longer and more sustained decrease in mean cerebral blood flow velocity after a midazolam bolus in preterm neonates who receive midazolam. So this is the perfect setup for IVH or PVL and likely explains the results of the no pain trial. This prolonged sustained decrease in mean cerebral blood flow velocity could be a setup for IVH or PVL in these babies, and explains why this drug doesn't really have a prominent role in the care of preterm infants today. Not only is it concerning as a short-term sedative, it also has long-term concern in my mind. So this is another zoomed-in picture of a neuron, and now we're going to look at the intrinsic and the extrinsic apoptotic pathway. These are pathways that are necessary in the developing brain to promote things like pruning. When you have rapid development, you also have to prune out neurons that aren't meant to be part of the long-term survival of the brain. But that pathway should function appropriately in homeostasis, not be altered by interventions like midazolam. So benzodiazepines, they downregulate the BCL2 protein and upregulate the Bax protein on the surface of mitochondria. And the downstream effect of that is increases in mitochondrial calcium levels, which set off the caspase cascade. Not only do you have that activation of the intrinsic pathway, you also have upregulation of the Fas protein on the surface of the neuron, which which feeds back on the intrinsic pathway and also promotes pro-caspases on its own. The net result of these three effects are dramatically increased in neuronal apoptosis in the developing brain. Like I said, apoptosis is a normal part of brain development, but out of control apoptosis contributes to changes in brain growth and development that we see in babies that are exposed to midazolam for long periods of time in the neonatal intensive care unit. But for both reasons, I don't think midazolam has a really prominent role in the care of our preterm neonates and should be avoided. We'll spend the rest of our time focusing on opioids, which are much more common agents utilized in preterm neonatal sedation and analgesia today. So in terms of their mechanism of action, they act on G protein coupled mu-opioid receptors. So when opioids bind to these receptors, you get downregulation of adenylate cyclase, which decreases the formation of cyclic AMP. You get blockage of the G proteins that allow the influx of calcium, so you don't get the change of that neuronal charge from negative to positive. And you get a forced efflux of potassium, which again hyperpolarizes that neuron in a negative state. Or in response to a painful stimulus, you have, again, far decreased levels of glutamate crossing from the presynaptic to the postsynaptic neuron. This is very good in the acute setting, and again, I can't emphasize this enough. So in the setting of a major painful stimulus like invasive surgery, you get reduced neuronal metabolic rate, reduced excitotoxicity, and reduced acute neuronal injury. Opioids are absolutely neuroprotective in the setting of major surgery. Just to make that point even more clear, I'll emphasize the landmark trial from 1987 by Dr. Sunny Anand, where he randomized babies undergoing PEA ligation to 10 mics per kilo of fentanyl or no analgesia. And you can see just these biomarkers of adrenaline and blood glucose represented in the blue lines were dramatically increased in babies who did not receive fentanyl, whereas those stress responses were blunted in babies who received fentanyl. In addition, babies in the fentanyl group had better short-term outcomes. They had higher survival. Again, this is a vital component of modern neonatal care. However, when we look at continuous infusions, and I'll make this point over and over again, dose and metabolism really matter. So we can't really bucket all opioids together. I think that's why randomized controlled trials ran into some trouble, because a continuous infusion of morphine or fentanyl is not the same regardless of dose. The dose really matters here. So in the top half of this slide, I have the dosing approach utilized in the NeoPain trial, and you can see that they gave higher doses for babies at greater gestational ages, and this is explained by the pharmacokinetics of the drug. With higher levels of renal maturity, babies might require higher levels of morphine to sustain similar concentrations. However, we know from recent work from Dr. Ruth Grunau's group that the picture is much more complicated than that. And this is a paper that I would love for everyone on the call to read in the detail that it deserves. But just briefly for the purpose of this talk, what it emphasizes is that differences in morphine metabolism correlate with the outcomes of babies who receive morphine infusions in the neonatal intensive care unit. The same dose does not produce the same level and therefore the same response, either acutely or chronically, in all preterm babies in the NICU. Genes matter. Genes that carry morphine into the brain matter, and genes that dictate how the baby metabolizes morphine to its metabolites, morphine 3 and morphine 6 glucuronide, as well as elimination from the body. All those things contribute to the correlation between morphine exposure and long-term neurodevelopmental outcome. So I reference this complex study not to get caught in the details, but to make the point that we have a long way to go. Optimal dosing of continuous infusion morphine for preterm babies who require sedation during mechanical ventilation. Simplistic dosing based on maturation of renal function really doesn't cut it. And in terms of the outcomes of the NeoPain trial, they were disappointing. Despite the really promising findings of the pilot NoPain trial, the NeoPain trial found no impact on severe IVH, PVL, or death. The NeoPain trial also clearly documented acute adverse effects from exposure to morphine, and those include prolonged time to extubation and delayed tolerance of full enteral feeding. And those are really baked in. Regardless, you're going to see those adverse effects when you put a baby on a continuous infusion opioid. And I think we need to really consider other drugs if we want to avoid those short-term adverse effects. Not only am I concerned about the short-term adverse effects from opioids, I'm also concerned about the long-term neurodevelopmental impact. So again, now we're zooming zoomed in on the surface of a neuron, we're really looking very closely at the G protein coupled mu opioid receptor and what happens when you have chronic stimulation of that receptor as mimicked in a continuous infusion in a neonate. You get activation of protein kinases, so protein kinase C and G protein receptor coupled kinase. These kinases phosphorylate the G protein, causing it to uncouple from the mu opioid receptor. When that uncoupling occurs, it allows the mu opioid receptor to couple with beta-arrestin. Now, depending on the cell, the fate of that cell, beta-arrestin basically pushes it in one of two negative directions. It can bind to ERK, which is extracellular regulated kinase, which downregulates cell cycle progression. So if that neuron is meant to go on to propagate and develop and help grow the brain, that is less likely to happen when it's stimulated persistently with opioids and beta-arrestin coupling occurs. If that's a cell that may go on to apoptose, beta-arrestin could couple with apoptosis signal regulating kinase, and that upregulates apoptosis. What you have with chronic opioid receptor stimulation in developing brain is increased cell death and less cell cycle progression, the worst possible setup for a rapidly developing, maturing preterm neonatal brain. In terms of clinical data, long-term follow-up from the NeoPain trial was really, really limited. There was only single center follow-up of 19 babies, so I won't spend our time there. I will talk briefly about the results of the European morphine trial, which importantly had a slightly different dosing strategy. They used 10 mics per kilo per hour of morphine for all babies regardless of gestational age. So a pretty dramatic difference in dosing for the babies on the higher end of the gestational age range in the European morphine trial compared to NeoPain. In terms of outcomes, the European morphine trial showed no impact on severe IVH, PVL, or death, similar to the NeoPain trial. Of interest, they showed lower IQ in the morphine group at 5 years, specifically emphasizing the subscale of visual analysis. However, they showed better executive function at 8 to 9 years in a subset of babies followed up, with subscales of inhibition, organization, and monitoring being emphasized. This is a really complicated finding, the dichotomous outcomes of this at 5 and 8 to 9 years. The best expertise that I've heard suggests that these findings are likely overall null, and emphasize that low-level morphine exposure likely does not have a profound impact on long-term developmental outcome at 5 or 8 to 9 years, given the subtlety of these findings and the small signal in these randomized control trials. I think the real concerning data comes from open label experience. So as I said earlier in the talk, the AAP and the Canadian Pediatric Society say don't use it. The Italian Society of Neonatology says go ahead and use opioids for sedation during mechanical ventilation and titrate them to scores. I think in most practices I've seen across the United States, we're taking the latter approach. If we see a baby who's agitated on the mechanical ventilation, generally there's an intervention, and that intervention is either morphine or fentanyl. And retrospective series that have looked at the outcomes of those babies have produced concerning results. So this is data from Stephen Miller's group when Stephen was in San Francisco and Vancouver collectively. And you can see there's a strong correlation between morphine exposure before term equivalent age and decreased cerebellar growth at term equivalent MRI. I emphasize the median morphine dose in this study, and it'll be important to contrast that with findings we review in the next couple of slides. Importantly, in this study, it wasn't only decreased cerebellar growth that they find correlated with increased morphine exposure, but also poor motor scores and cognitive outcome at 18 months corrected age. So phenotypic finding in brain development, as well as a developmental outcome concern correlating with increased morphine exposure before term equivalent in preterm babies. We also published a similar study, and this data came from Australia, but it was work we did at WashU. We looked at the outcomes of babies who had term equivalent MRIs in Australia and the correlation between their morphine exposure and brain growth. And we found nothing. So we found no correlation between morphine exposure and cerebellar growth or growth in any other region of the brain. So on the surface, findings, and these papers came out at a very similar time. I was very nervous about our findings in the setting of Dr. Miller's group's findings because they contrast dramatically. However, if you look carefully at our data, and if I present it in a different manner than we did in the published paper, I made a graph that really similarly mimics the way that Dr. Miller represented their data. You can see why the difference in findings is not actually a difference, it's very similar. So the Australian cohort just didn't have high-level morphine exposure in the way that the San Francisco and Vancouver cohort did. This graph has the same scale, so you can see on the right side there's no baby. There are no babies with really high-level morphine exposure to drive that decrease in cellular growth, as was the case in the contrasting data from Dr. Miller. I think our studies really show similar things and emphasize again this point that I want you to walk away from the lecture having, is that dose and metabolism matter. Low-level morphine exposure very likely does not have a long-term impact, but when that morphine exposure becomes higher level, as could happen when you titrate scores to clinical effect, you're going to potentially see problems with cerebellar growth and long-term outcomes. I want to spend a really brief time on fentanyl because I think fentanyl has a very important place in neonatal intensive care, as I've already emphasized. That place is acute surgical management. If you have bedside surgery, giving an anesthetic dose of a synthetic short-acting opioid like fentanyl is vital. However, when we extrapolate that to use in all neonatal populations for all indications, it gets pretty dicey. So we have very well-designed dosing of morphine based on renal maturation and the pharmacokinetic studies to back it up. Until very recently, we didn't have that level of data with fentanyl as a continuous infusion. We use 1 mic per kilo per hour in all infants because that's the standard dose of fentanyl, regardless of age. And we published a paper about 5 years ago that suggested that that kind of dosing, fentanyl at a starting dose of 1 mic per kilo per hour and titrated effect, could result in massive exposure in preterm babies. And that exposure correlates with decreases in transverse cerebellar diameter, very much in the same vein as the work that Dr. Miller's group did with morphine. High-level fentanyl exposure produces the very same thing that high-level morphine exposure does in terms of cerebellar growth. So why do I couch 1 mic per kilo per hour of fentanyl as high-level exposure? I had to dig really far back with pharmacokinetic study from 2000. And if you look at this study on the surface, it doesn't look so bad. You can see that babies accumulate to some degree, but if they're only on 1.5 mics per kilo per hour of fentanyl, that accumulation stops after about 24 hours and they really level out at steady state. However, if you look at this trial in more detail, babies in this pharmacokinetic study were loaded with 10.5 mics per kilo of fentanyl. But anesthetic dose of fentanyl, and then on that low-level infusion rate of 1.5 mics per kilo per hour, there was still accumulation on top of that anesthetic level of fentanyl. When we're giving babies 1, 2, 3 mics per kilo per hour of fentanyl, specifically preterm babies, just to be clear, that's enormous levels of opioid exposure. And it's no surprise that we see problems with cerebellar growth and potentially impinging long-term outcomes as well. This retrospective data has been bolstered by recent randomized controlled trials, also from the Italian groups. So in 2013, they published an important paper in Journal of Pediatrics. So this trial randomized babies to fentanyl or placebo for stable mechanical ventilation as compared to morphine or placebo. The 2013 trial didn't get me very excited. There was no impact on open label boluses per day, which I think raises significant questions about efficacy. Duration of mechanical ventilation was prolonged, not surprising, and time to full enteral feedings was also, there was a trend towards prolongation. Not surprising at all based on everything we know from the NeoPain trial about the short-term impacts of opioids. However, really concerning findings came out in 2017. They followed up a subgroup of babies, and there were trends towards higher rates of developmental quotient and standardized quotient scores at 2 years in babies randomized to fentanyl as compared to placebo. Now, importantly, the group got much smaller, and the fentanyl infants at this stage were less randomized, I guess. They were still randomized groups, but they were less the same as they were in the beginning of the trial. The fentanyl infants had higher crib scores, which could have led to these long-term concerning findings. But this is the randomized data you have with fentanyl when you're using it in clinical practice. It's at best mildly concerning and at worst a major concern in terms of potential long-term impact. I would not use fentanyl as a continuous infusion in my clinical practice for preterm babies unless I was using very, very modern pharmacokinetic data. Unfortunately, that pharmacokinetic data is now available. It came out, I think, about 8 to 12 months ago in archives, and you can see that you have to really dramatically lower the rate of continuous infusion fentanyl in very preterm babies, especially early in life, to get the same level of exposure as produced by 1 mic per kilo per hour much later in their developmental status. So I would read this study very, very carefully if you're using fentanyl in your clinical practice, and I would just adjust dosing accordingly. So that portion of the talk is a big downer. I'm not a huge fan of opioids for this indication. Stable mechanical ventilation shouldn't be painful per se. Again, these drugs have a really, really important role in our acute management of painful stimuli. But what are we really dealing with long-term stable mechanical ventilation? And do we have drugs that may be more appropriately indicated for sedation in that setting that could have potentially less long-term neurodevelopmental impact as well? And my assertion is that those drugs are alpha-2 agonists. Alpha-2 receptor agonists work in a very similar way to opioids. They bind to G protein-coupled alpha-2 receptors and produce really, really similar pharmacologic effects to opioids. However, they do it in a very focused region of the brain, presynaptic neurons and the locus coeruleus. They do have analgesic properties, but they also have profound sedative effects. And I think this is exactly the kind of drug that makes a lot more sense during stable mechanical ventilation. A sedative, not midazolam, but a sedative as opposed to an opioid. Clinical data with dexmedetomidine in preterm infants is very limited, but it's very promising. When compared to fentanyl, babies receiving dexmedetomidine have fewer days that require adjunctive sedation, so suggesting that it works, which fentanyl compared to placebo does not. There's a shorter duration of mechanical ventilation, which makes a lot of sense because dexmedetomidine does not suppress respiratory drive, whereas opioids do. And you have a shorter time to full enteral feedings. Dexmedetomidine does not suppress the activity of the GI tract, which opioids are very well known to do. I think the real enticing property of dexmedetomidine that I'm excited about and I think deserves careful examination in randomized trials is the potential for neuroprotection. In preclinical models, dexmedetomidine has been shown to reduce lesion sizes in experimental PVL. It protects against brain matter loss and improves neurologic function in hypoxia ischemia. We'll talk a little bit more about that in a sec. And it attenuates neuroapoptosis and prevents long-term memory impairment when the animals are exposed to other neurotoxic pharmacologic agents like isoflurane. We actually have a good idea of how it does that. It's contrasted with the impact of midazolam on the intrinsic and extrinsic apoptotic pathway. Dexmedetomidine upregulates BCL2 proteins and downregulates Bax proteins, which causes a suppression of apoptosis. In contrast to the action of morphine and other opioids on G protein coupled receptors, alpha-2 agonists with persistent stimulation upregulate ERK, which upregulates cell cycle progression. So decreases apoptosis, promotes cell cycle progression, potentially a really good thing for the developing preterm brain. So with that, I'll move on. I hope I have a little bit of time. Yeah, sorry, I'll go really fast through this material since I'm about out of time. A real emerging focus in our lab and something that we want to do a better job of moving forward is sedation during therapeutic hypothermia. I think that all units should be at a minimum taking the standard approach with morphine at a loading dose followed by a low-level continuous infusion. It's really important that you bolus for agitation, but do not increase the infusion rate because this doesn't acutely address agitation. And babies undergoing therapeutic hypothermia have two reasons to accumulate morphine. One is organ dysfunction from the hypoxic hit, but also the cooling itself impacts morphine metabolism and elimination. Sticking with this continuous infusion rate is the safest way to sedate a baby during therapeutic hypothermia. I think a potentially better approach is dexmedetomidine. I've listed the doses that's been used in the published clinical reports to date. You have to really work with this drug cautiously because it can have impacts on heart rate. And we know these babies are bradycardic at baseline, but there are emerging case series that suggest that this is a viable sedative in this setting. And again, it could be really beneficial to the developing brain in the setting of hypoxic ischemic encephalopathy as well. The case for morphine is that shivering and agitation likely counteracts some of the benefits of therapeutic hypothermia, and that morphine has been utilized as standard of care in some trials of therapeutic hypothermia. There's phenomenal pharmacokinetic data to guide dosing, as I've already emphasized. If you're using this drug, use it based on the great pharmacokinetic studies that inform how we can safely give this drug to provide sedation that will potentially preserve or augment the benefits of therapeutic hypothermia. And I just emphasize one of those pharmacokinetic studies here that make the point for the last time that dose and metabolism really, really matter in this setting as well. The case for dexmedetomidine, I think, is strong, though. We already talked about those animal models that suggest neuroprotection in the setting of hypoxic ischemic encephalopathy. It directly blunts shivering in humans, which is one of the goals of sedation during therapeutic hypothermia. You get this with no respiratory depression. So you will not have to intubate babies who receive too much dexmedetomidine, which is a direct contrast to morphine. I think this intervention really deserves a randomized controlled trial as an adjunct to therapeutic hypothermia, both from a compassionate care perspective, as well as a long-term neurodevelopmental outcome perspective. Just for your reference, I've put up a potential guideline for how you would initiate and titrate dexmedetomidine during therapeutic hypothermia to avoid adverse effects and deal with agitation and shivering. So in summary, analgesia for major acute painful stimuli dramatically improves neonatal outcomes. I've starred a review that I wrote on sedation for endotracheal intubation. I think that's vitally important. And again, if with time, I would have shared that material, but I'll just reference you to that review. The role of long-term sedatives in analgesics is much less clear. Midazolam increases the risk of brain injury and likely produces significant neuroapoptosis, so I would avoid that. Morphine has adverse effects, but it has the most data. So if you use that drug, please consider dosing and metabolism when you use that intervention. Fentanyl, if you're not using it based on modern pharmacokinetic data, you're not doing the right thing by your babies. In the setting of the known toxicity of both of these drugs, I think dexmedetomidine deserves careful consideration and investigation for the care of our preterm babies undergoing mechanical ventilation and for babies receiving therapeutic hypothermia. And with that, I will gladly take your questions. I'll go back to the first slide so that my email address is up on the screen. Please email me if you have questions, if you want the slides, if you want any of the references. I'd love to dialogue with anyone after this talk if they have any questions or comments.
Thank you so much. It's a great talk. Actually clarified a lot of things. Let me see if you have any questions here. If not, I can start. All right. So I know Versed, we are moving away from Versed. What about the Ativan, the lorazepam? Is there any role for that?
For preterm babies, I don't think so. It's a longer acting agent. It certainly has a role in potentially in term babies and babies undergoing weans from midazolam, who, again, if term baby sedation management is a totally different kettle of fish, in that those babies benefit from multimodal sedation. They have much fewer adverse effects to benzodiazepines in terms of blood pressure than preterm babies. I would really strongly avoid all benzodiazepines in preterms, both for short-term adverse effects as well as long-term neurodevelopmental outcome concerns. But those drugs do have a role in the management of term babies who require real strict ventilator synchrony to survive their more short-term insult in the setting of a much more stable developmental stage of brain growth.
Thank you. I think I see some questions here. So this question, how do you dose your Presidex or dexmedetomidine for any type of infant requiring continuous sedation?
Yeah, so in preterm babies, we start at 0.2 mics per kilo per hour. We titrate by 0.1 mic per kilo per hour to effect, monitoring very, very cautiously for heart rate and blood pressure. We do not bolus with dexmedetomidine in any clinical circumstance. That's a surefire way to elicit the adverse effects that are definitely a component of this drug that include bradycardia and hypotension. Based on the limited available data in babies who are undergoing therapeutic hypothermia for hypoxic ischemic encephalopathy, we start at 0.3 in that circumstance and titrate in a very similar way. Again, very cautiously monitoring for bradycardia.
Okay. Any PET scans on any of your kids who use Presidex? Any data on that? Anything?
No, we have exclusively MRI data, and our MRI data was done in an era when utilization of morphine in Australia, fentanyl in the St. Louis Children's NICU. We have not done MRI studies of babies receiving Presidex in our unit. We haven't honestly used it long enough, and don't have a clean cohort of babies who have been sustained on dexmedetomidine monotherapy to undertake such a study.
All right, wonderful. Another question is, does caffeine and morphine together increase apoptosis?
That's a whopper. That's a fantastic question. So I am aware of data that's been presented at conferences, but my knowledge has not been published, suggests that the combination of anesthetics and caffeine augments apoptosis. I'm not aware of data on the combination of morphine and caffeine specifically with regard to apoptosis, though I'm really not a fan of this combination in clinical practice. I understand the role of caffeine and the importance of caffeine. I understand the retrospective studies that suggest the sooner you get it on, the better. But there is also concerning data with caffeine in terms of both short-term issues with brain bleeds, as well as potentially a negative impact on long-term developmental outcome when we get into the area of high doses or extremely early caffeine. I don't understand the clinical scenario where caffeine is beneficial in a baby here. You're trying to promote ventilator synchrony to the point that the baby requires morphine. So I think I want to get caffeine on board as soon as possible. But remember, in the CAP trial, caffeine was given to facilitate extubation or to prevent apnea. It was not given for babies on oscillators, for babies requiring continuous morphine infusions. That's just not where the benefit has been shown in clinical trials. So I'd approach that combination very cautiously, and in my clinical practice, we avoid it.
Thank you. Are there objective tools we could use to monitor appropriate sedation with using Presidex?
There's a mint for someone who figures out that answer. I think, unfortunately, the answer at this time, clinically applicable tools, not really. I'm really interested in skin algesimetry. I'll pronounce it poorly. I think there's a lot of potential in a lot of different things, but I think clinically applicable bedside tools to measure pain or agitation in neonates have been elusive so far. And that makes this game very tough in terms of judging the acute efficacy of the drugs we're using, which is why I'm a wimp and I focused on long-term outcomes, because I think the acute effects of these drugs outside of the setting of real major acute procedural pain is extremely challenging to judge.
Okay. Any role for clonidine, especially for shoring in therapeutic hypothermia?
Yeah, so it depends on where that question is coming from. So we don't traditionally utilize intravenous clonidine in the United States. There's great data with that approach in Europe, and if that is your alpha-2 agonist, intravenous alpha-2 agonist of choice, I think that would have, in my mind, equivalent benefits to dexmedetomidine. In the US, we traditionally have clonidine either intrathecally or orally. It's definitely useful as a weaning tool, oral clonidine after a long course of intravenous dexmedetomidine, not necessarily something you would need in the short duration of therapeutic hypothermia. But if you're using dexmedetomidine for over a week in a term infant, for example, or a preterm infant who requires long-term sedation, I think oral clonidine has a really important role for weaning babies safely off that alpha-2 agonist if they're able to tolerate enteral feeds at that point.
So the withdrawal symptoms will be similar to the opioid withdrawal with the dexmed?
Hopefully not. You should see less of the traditional NAS type symptoms and more cardiovascular adverse effects. So hypertension, tachycardia, things like that have been more commonly reported. Although there's definitely much less data on withdrawal from alpha-2 agonists as compared to opioids or benzodiazepines, which have been really thoroughly described.
Okay, great. Is it possible that morphine, fentanyl, or Presidex, they can alter the EEG or augmented AEG or regular EEG?
Yeah, the answer, I wish I had a better off-the-cuff answer to that question. I know that dexmedetomidine promotes better sleep-wake cycling on EEG. Benzodiazepines can obviously alter an EEG. They have major anti-epileptic properties. To my knowledge, I'm not sure that opioids directly alter EEG. So that's my off-the-cuff, very poor answer, but I definitely have to take a look at the literature to give a solid answer there.
Okay, perfect. Next question is, in post-op setting, is there data or studies that indicate opioids can be reduced with Presidex administration and improve analgesia?
That's a great question. I am not familiar with that data if it exists. The drug that very decisively lowers opioid requirements after an operation is IV Tylenol. So I think IV acetaminophen has a really important role in that setting. I know that it's become kind of a bad word in many health systems because of the cost relative to oral or rectal acetaminophen. As neonatal providers, it's important for us to understand that number one, the randomized controlled trials showing benefit for IV acetaminophen postoperatively are in neonates. So we have the data. The adults and older pediatric patients don't necessarily have that level of data. And there's great data in neonates suggesting that absorption from rectal Tylenol is incredibly erratic. So you get a much more reliable serum concentration with IV acetaminophen compared to rectal acetaminophen after a major operation. So I'd really fight for that drug in your neonates. I'm not saying use it like water in your entire medical system because it could bankrupt the whole thing, but in the neonatal intensive care unit, it has a very clear role and good data to back it up. I'm guessing that dexmedetomidine would help with postoperative analgesia and sedation as well, but I'm not aware of data that really explores that in detail.
All right. Is there a maximum dose of Precedex?
A great question. It's not entirely clear. Most centers max at 1 mic per kilo per hour. There are certainly case reports that suggest that higher doses have been utilized. In my clinical practice, I have not utilized doses higher than 1 mic per kilo per hour. So if a baby was on that dose, tolerating it well, and still experiencing agitation, I would look very hard for other causes of agitation, but also consider an adjunctive agent at that point.
All right, and I think there's one more question here. Do you have a pattern for starting clonidine when you transition from IV Precedex?
Yeah, that's a really, really important and good question as well. There was a reference on the last slide, an article in Journal of Perinatology that's coming out. It's in press. It's coming out whenever they choose to put it out. I give a very clear conversion from IV morphine to PO morphine, IV fentanyl to PO morphine, IV midazolam to PO ativan, and then IV dexmedetomidine to PO clonidine. I don't want to confuse the matter by coming up with a bad off-the-cuff math answer, but I think that data it's not really readily available in any references that I can get a hold of. So I published it. So look for that table in that Journal of Perinatology article that should come out before the end of the year, or email me and I'll send you the Word document. It's really important to have that in your toolkit. We have an approach that works in our practice, not phenomenal empiric evidence to support it, and I'm not aware of anybody that's published that yet, but we'll give you an approach that works.
Wonderful. I have a research question because we follow the babies. I have a follow clinic, so I was looking at these doses. Is there a software or anything where you can look at these cumulative doses? Because it's so difficult to go to each chart and look at these medications, especially Precedex, which we are using quite a bit in our units. Is there a way we can do this cumulative dosing, not only for Precedex, but on other medications, morphine and other medications?
Yeah, if there is, I have a WashU undergrad who collected all the data for our studies who will kill me. We did it manually. I am not aware. We've transitioned through 3 different electronic health records since the first study was undertaken. And in an EPIC, which is a decent electronic medical record, I'm really unaware of anything that will give you cumulative dose without a lot of manipulation of some ugly Excel spreadsheets. I think it's a great point that we often in the acute care of these babies lose track of cumulative exposures. And I think that's why it just has to be a conscious decision every day to think about both the benefits and the risks of the sedatives we're using when we have those discussions on rounds. And I do not want to underemphasize how difficult this area is, balance between drug effects and compassionate neonatal care, which is why I'm just really excited to explore different agents that might be able to provide the sedation we think all these babies deserve when they're agitated without the adverse effects from the drugs we've historically utilized.
Wonderful. Let me see. Yeah, I think that's Oh, one more question here. Any gender difference of preterm infants according to their outcomes?
Oh boy, we did not look at that. We could look at that. We did not look at that. It's something that we could definitely explore. But yes, that was not something. Genetics matter, so I would not be surprised if there were, but we did not look at that in any of our studies.
So can we safely say boys don't do better?
I would guess not. Generally speaking, that's kind of a hallmark of neonatology. But in this one, based on the most recent genetic work out of Dr. Miller's group, I think that's a really underexplored area. So something we should look carefully at. Yeah.
Wonderful. Thank you so much. I don't see any more questions here. And again, thank you so much for your presentation. It's very, very, very helpful for our clinical practice. Definitely, I think we are going to look at our practice again to make some changes. And again, we'll be in touch with you with our questions.
Thanks so much. And anybody on the chat, please email me. Don't hesitate. I'm happy to share the slides or any of the references. It's really a pleasure to spend time with you guys virtually today.
Perfect. Thank you and have a great day and nice weekend. And thank you, everybody. Have a nice weekend.